Dr. Gary Sykes, obstetrician, Sydney Men's Hospital. I remember when I was a young resident, I did epidurals. We did them on public patients. There were no obstetric registrars, even though it was a teaching hospital. And so, yes, I did some epidurals myself. But I'm pleased to say that times have changed. And now we have, at the Sydney Men's Hospital, fully qualified, extremely experienced anaesthetists who provide an epidural service. What that means is that for the women, they tend to work extremely well. Now, some women have a back, they can have more fibrous adhesions in that epidural space so that the anaesthetic fluid doesn't flow as well. So they'll have what we call a patchy block. So they will have an area of discomfort. Women can get upset about this because I thought that the epidural would be fully effective, but sadly, for this reason, it's not always. It's nothing to do with the anaesthetist, it's got to do with their anatomy. The anaesthetist sometimes will recite it in these cases, but even after reciting the epidural, they may not have a good result. It's just one of those things. But certainly for the majority of women, they have excellent pain relief. Girls tend to be more mobile than they used to in the past with epidurals. And patients tend to be very, very happy. Patients tell me they're worried about the risk of epidural. Personally, and I've had many thousands and thousands of women, patients who've had epidurals. I've never had one yet that's had a severe complication. So I'm not worried. Yes, there are theoretical, and you hear of cases when there are serious complications, but in my experience, I have never had a woman yet who's had an ongoing problem related to an epidural block. So I'm quite happy. I don't think that should be a reason for not having an epidural. Now, some women don't need an epidural. That's fine. They have a very straightforward labour, and I have numerous patients that do. But if a woman comes into labour ward, birthing unit, as we call it now, and she's only in early labour and not coping, an epidural is a good way to go. Personally, if I was a woman, I would have an epidural. It's a bit like, I use the comparison, a bit like me going to the dentist, and the dentist offered me some local anaesthetic, said, no, I don't want local, I'm tough. I don't see any reason for being tough. I tell patients, if you have an epidural block, you can lie there with your husband, you have a game of cards, watch some TV, read a book, whatever, and first stage labour just progresses, and you don't have any pain. To me, that's good, it's very good. But, certainly not every woman needs an epidural. I have many women who don't have epidurals. So it's an individual choice, individual preference. So some women are very fearful of the labour pain, that's fine. They can have an epidural at the outset. Some women elect to be induced where they want to have an epidural before the induction. They don't even want to have any discomfort related to being induced. That's fine as well. So everyone's a little bit different in how they approach this, and we can't generalise. We've got to give the women the right to make their own decisions, individual choice, rather than us having a bias and trying to steer a woman in a particular direction based on our bias. We talk through what is available and let them choose what they want to do with their labour and their childbirth experience. Now, when it comes to second stage, a lot of women here that if they have an epidural, it's more likely they won't be able to push their baby out and they'll need an operative vaginal delivery. From my perspective, I don't agree with that. It's got to do with how that second stage is managed. If a woman has an epidural block on board, yes, it is harder for her to push. So I'll prefer the midwife to leave her in second stage, passive second stage, without any pressure. That could even go on for a couple of hours, just to allow the baby to descend through the pelvis. And so when the head's very, very low, then get her pushing. If she does that, then it's highly likely that she will have a normal vaginal delivery. If she gets her pushing too soon, such as soon as she's diagnosed fully dilated and the head's still quite high, then no, that won't work. It's highly likely that women will find it very difficult to push the baby out and will need an operative vaginal delivery, which is an unnecessary operative vaginal delivery, which could have been avoided if we'd managed her second stage differently. So I'm very conscious of this with my patients. Just because they're in second stage doesn't mean to say it needs to be active second stage. We can leave them, allow the head to descend, and when the head's right down on that perineum, then she can start pushing the baby out. That optimises the chance of having a normal delivery and an intact perineum, which is the ultimate goal.